This season, we've watched channels sense voltage, stretch, ATP, and acid. In this finale, it senses something deeper: the cell's own energy state, metabolism itself. KATP, a switch that wires how much fuel is left in the cell directly to whether it fires. It's the target of the oldest diabetes drugs and the stage of one of the most beautiful precision medicine victories in medical history. First, what it is. KATP is an ATP-sensitive potassium channel built from two parts. Kir6.2 is the central pore, and SUR1 is its regulator, the receptor for sulfonylurea drugs. The rule is simple. When cellular ATP is high, well-fed, it closes. When ATP is low, energy scarce, it opens. In a pancreatic beta cell, blood sugar rises, ATP climbs, KATP closes. The cell depolarizes, calcium enters, insulin is released. It is the switch that wires metabolism straight to insulin. From this switch grew a most classic drug class, the sulfonylureas. Old oral glucose-lowering drugs like glibenclamide bind SUR1, close KATP, and force the beta cell to release insulin used for decades. In reverse, diazoxide opens KATP, treating the excess insulin state of hyperinsulinism. One closes, one opens. That's the landed half of this line. The other half is a miracle. There's a neonatal diabetes, where babies are diagnosed diabetic in their first months of life. It turned out many carry activating mutations in KCNJ11 or a BCC8, exactly the Kir6.2 and SUR1 parts, jamming the channel stuck open. So the beta cell can't fire and no insulin comes out. The astonishing twist: a sulfonylurea pill can close that mutant channel back down. Babies once on daily insulin injections were switched to oral pills, and it worked. The genotype directly chose the drug, the dream of precision medicine, realized on a single ion channel. There are limits to respect, of course. KATP is everywhere: beta cells, heart, brain, vascular smooth muscle. Sulfonylureas closing KATP can affect the heart's ischemic protection and can push blood sugar too low. So you must tell apart the pancreas's SUR1 combination from the heart's SUR2 and the vessel's SUR2B, back to the word that ran through the whole season: selectivity. And testing KATP is unusual. It's metabolically gated, so you give a TP and ADP directly in the patch clamp, often inside-out patches with precisely controlled nucleotide levels. And you must reassemble Kir6.2 with the right SUR subtype: pancreatic SUR1, cardiac SUR2A, vascular SUR2B. Measure sulfonylurea and opener binding, subtype selectivity, and nucleotide sensitivity. Whoever can measure the right components cleanly, in the right nucleotide background, holds the key to metabolic channel drug discovery. For the season finale, one line on KATP. It's an ATP-sensitive potassium channel, Kir6.2 plus SUR1, wiring metabolism to insulin. Sulfonylureas close it to lower sugar. Diazoxide opens it for hyperinsulinism. In neonatal diabetes, the genotype directly picks the sulfonylurea pill, a living sample of precision medicine. Test it with nucleotide-controlled patches and correct subtype assembly. And looking back across all 8 channels: CFTR, KV7, NAV 1.1, TRPV1, PIZO, P2X3, ISIC, KATP1 lesson repeats. The channel is never simple. The trap is always selectivity, and the winners either found selectivity or found it in venom or in a patient's own genes. The bottleneck was never the idea, it was whether you can measure the channel cleanly. That is exactly what we do. Follow Channel Observatory if you need your channel measured. Come find us.